Maria Valentin is a physician. He received MD from the University of Valladolid in 1999 and was fellowship at Hospital 12 de Octubre in Madrid, where she became a specialist in nephrology, and she obtained her doctorate from the Universidad Complutense de Madrid in 2016. And Dr. Valentin has been working since 2005 at the Organización Nacional de Trasplantes, a Spanish transplant organization in Spain. Maria, when you want.
Okay. Well, good morning to everyone. Thank you very much to the project ECARIS to give me the opportunity to share with you some information about this very, very important topic, which is the preemptive kidney transplantation. I'd like to start my presentation showing you our figures on kidney transplantation all over the world, because as you know, kidney transplantation is the best treatment for end-stage renal disease. And as you see, every year we perform in the world, as you see with this data of the Global Observatory on Donation and Transplantation, close to 100,000 transplants. That do the benefits of kidney transplantation change over time? To answer this question, I want to show you this very nice study performed in 2002, in which the authors compare the graft survival, the survival of the kidney after the transplantation with the deceased donor in the left side of the screen and with a living donor. And this comparison has been done at different moments, performing the transplant in a preemptive way before initiating dialysis or after 6 months, 1 year, 2 years, or more than 2 years. And as you can see, because the differences are quite significant, preemptive treatment is the best option because the results are much better than with the rest, over the rest of the moments after 10 years. So time under dialysis is an independent risk factor for renal replacement, for renal transplant outcomes. That preemptive kidney transplantation not only has an advantage for the graft survival, but also for patient survival. And this is other study that I'd like to share with you. This is the survival of the patient transplanted, preemptive or non-preemptive with the cadaver donor kidney transplant and with the living donor kidney transplant in the right side of the screen. And as you can see also, preemptive treatment gives better results. This study is performed, has been performed in adults, but these results are the same in children, as you can see in the left side of the slide. This is the line in black, is kidney transplant performed preemptively with a living donor. And this is the graft survival estimation, which you see that is better than with other type of transplantation. And if we go directly to the data, after 5 years of the transplant, the percentage of graft survival is much higher with a living donor preemptive transplant than with the rest of the transplant options. But preemptive kidney transplantation is not only excellent treatment to improve patient and graft survival, but also it avoids comorbidities associated to the end-stage renal condition, such as anemia, bone mineral regulation, cardiovascular disease, or the techniques of dialysis, and the possibly negative effects or side effects of the procedure access to dialysis, such as catheters or the arterial venous fistulas. And the reduction in these comorbidities results in less hospitalizations, which may improve patient employment status. And this is very, very important for the quality of life of a renal patient. But in children also minimize the effects of cognitive function and growth severely affected in the end-stage renal disease. The last one is the cost saving. It may not be very important for a patient because these other items are much important for them, but for healthcare systems, cost saving is also essential. Then, well, with this answer, we may say, okay, let's do preventive kidney treatment for everyone, for every patient in need. But when we put the attention in the figures, the results are much worse than expected because, for example, in USA, only 2.5% of their recipients receive a preemptive kidney transplants. In the whole continent of Europe is 4%, but there are countries such as Holland or Denmark with higher figures, but also a low percentage taking into account that preemptive treatment is the best option. And it is because of the lack of donors. What are the figures in Spain? Well, they are quite similar to those at the European level. As you can see in the line green is the preemptive treatment as the initial treatment modality for incident end-stage renal disease cases. And you can see that during the last 10 years, we have increased our percentage of preemptive treatment, but since 2013 is established in between 4 and 5%, which are low figures. And as I told you before, we have an important donor shortage for preemptive kidney transplantation. You may know that Spain has a very, very high rate of deceased donation, and we perform many transplants every year. As you can see in the line in red, we perform almost 4,000 kidney transplants every year, but we only get our patients transplanted every year in the half of the cases, as you can see in the below in the slide. The figure, the part pink of the figure is the waiting list, and the blue part of the figure is the kidney transplantation. You see a very big gap between the waiting list and the transplantation. So what is the answer then? The answer is living donation. Living donation can expand the available kidney donor pool, and it can be done preemptive because it can be we can decide the best moment to perform the transplantation, and it can be done before initiating dialysis. And if we talk specifically with living donation, every type of kidney donation gives excellent results. Also compatible, total compatible living kidney donation, but also when there is an incompatibility between the donor and the recipient regarding the blood type group. But an important concern of patients and families is the donor protection, because we are trying to find a suitable donor, and this person gives the kidney, but he has to be under major surgery, which is a nephrectomy. So for all the transplant community, donor protection is mandatory. And there are 3 items that it must be followed, must be meet this criteria for every a transplant team. The first one is a thorough evaluation of the donor that should be done from the point of view clinical and also psychological. The clinicians are required to outline the risks, not only in the short but also in the long term, and inform the donors candidate about this risk properly, and also of course assess that the donors candidate has understood these risks, because an informed consent here is mandatory. And of course any evidence of coercion, pressure or threat suspect must also be ruled out before going on with a living donation. The donor risk assessment should be done, as I have told you, thoroughly, because we must say that although living donation is a very low risk procedure, the perioperative mortality is now 0. It has been established in 3 donors per 10,000 donors, and it has not experienced changes over the last 15 years. But one thing that that worries our nephrologists is the potential risk of developing end-stage renal disease after a living donation in a healthy person. For that reason, some studies has been done in the long term, and this is a very important study performed in 2014. And as you can see in the right of the slide, below in the right of the slide, in the figure, you can see that the probability of developing an end-stage renal disease after a kidney donation is very low. This is the line in light blue, a live donor, and it is significantly lower than the general population, which is the one corresponding to unscreened non-donors, but is a bit higher as a healthy person that has not been a donor, and it should be put on the table and inform every donor. Trying to figure out what is the risk of the donors in the long term, and if every donor has the same risk, a clinical research was performed by this group of investigators in 2017. This is a very, very nice study, and it differentiates the risk of a donor to have problems with his kidney after 20 years, and it determines that the majority of the donors have a very, very low risk. Only 34 per 10,000 donors will have problems with with the kidney after 20 years, but there is 1% of the donors with a higher risk after 20 years, as you can see, and this percentage is quite similar to the general population. And the conclusions of this study that are very, very important, and that are included as a general recommendation in these international guidelines for the evaluation of care of living kidney donors, is that the risk factors have been evaluated, should be evaluating all together. The evaluation of the donor should be complete, not only isolated potential risks, but also clinical risk such as hypertension, diabetes, or demographic characteristics like age, gender, ethnicity, and so on. These are the data of the Spanish living kidney donor registry in their reports published in 2017. As you can see, we use minimal invasive surgical techniques with laparoscopy in almost 100% of our donors. We have 100% of perioperative survival rate, and the risk for reintervention is very low, is less than 100%. And the median time in hospital of the living donors is only 4 days. But there are other protection measures for the living donors to guarantee the quality and safety of the procedures, such as the traceability. All the transplant organizations have information of the donors and their recipients, because if there is a problem with the recipient, we can go directly and rapidly to the donor and vice versa. We have put in place biovigilance systems and quality assurance programs to manage potential adverse events. They are very, very low, but in case it occurs, we establish preventive measures. We protocolize the steps of the donation programs to gain quality of every process. And we have put in place living donor registries at local, national, and international level to increase knowledge on short and long-term results of our donors, as I have shown you before. And of course, all the countries has enforced policies and guidelines. This done at national, but also on international levels. These are our regulations on kidney donation, but there are also some ethical guidelines, such as the additional protocol to the Convention of Human Rights and Biomedicine concerning transplantation, or the WHO guiding principles on transplantation. This is done to protect the donor and to guarantee the minimizing of effects in the donation, as this procedure is now as a safety procedure with very, very low incidence of adverse effects. Well, with this information, I'd like to share with you that living donation accounts for 28% in Europe, but there are differences between countries. For example, the Netherlands has a very, very high rate of living donation, as well as northern countries or United Kingdom. The case of Spain is that we have a very high rate of disease donation, and we have a 10% of our living donation and 10% of our kidney transplantation activity is performed by living donation. Well, then we can say we have a quite nice percentage of living donors at 28%. These donors or these recipients then may have been transplanted preemptively, but it is not the case. Many patients are transplanted after initiated dialysis before, although they have a living donor. And the case of USA is that 1/3 of the kidney transplants performed with a living donor are performed after initiating dialysis. Why is it possible? Our main goal then is to achieve living donation preemptive treatment. We have a living donor, we try to make the transplantation before starting dialysis, because as I have shared with you before, is the best option, and the advantages are enormous if we compare them with the transplant after initiating dialysis. But to achieve this goal, we need a suitable living kidney donor candidate, of course, and the recipient should have a renal disease sufficiently stable to remain off dialysis while both the patient and the donor are studied or are under the evaluation progress. So the GFR, the glomerular filtration rate of the recipient when the process starts, it should be enough high to permit the recipient be several months before dialysis. How to get this goal? Well, timely referral of renal patients to the nephrologist is very, very important. And for that reason, education of patients, nephrologists, and physicians is essential. Information on renal replacement therapies and the offer of living donation as preemptive transplant should be done with enough time to make preemptive transplantation possible. But not only for preemptive transplantation. In case there is not a suitable donor and the patient must start dialysis before the transplant, it is very important that the patient is informed with enough time to decide what kind of renal replacement therapy, for example, hemodialysis or peritoneal dialysis, wants the patient to choose. And of course, it's very important the length of time to complete the donor assessment. If the donor assessment is performed in 2 months, the probability of making the kidney transplantation before starting dialysis is very, very high. But if the length of time is 1 year, the probability of the patient to be transplanted preemptively is quite low. So what can we do to achieve these goals? Well, we think that it is very important to increase living donation activity, to gain expertise, to improve the pre-end stage renal disease care units, and to make an efficient evaluation process. And what have we done in Spain? Well, we have taken measures to increase activity, and we have made a survey for transplant centers self-audit in order to find those areas of improvement to inform properly to the patients and with enough time before starting dialysis, and to make the donor assessment more efficient. Well, the measures taken to increase the living donation activity has been as follows: training measures of our nephrologists, promotion in collaboration with the patients association, the development of clinical guidelines to help our nephrologists to study the donors with evidence-based medicine, to put in practice the living donor registry to know what happens with our donors after the surgery, and to be sure that it is a safety procedure. And in case the pair, the donor and the recipient, goes to be assessed for a living donor transplantation, and there is not compatibility between the donor and the recipient, to offer different approaches to make the transplant possible. For example, in case there is a pair and the donor is not compatible with the recipient, a kidney exchange program has been developed in Spain to exchange the donors of different non-compatible pairs to obtain new compatible pairs in which the transplant can be performed. Also, the altruistic donor program, which is based on a person that wants to give a kidney, but that person doesn't have a next of kin or a loved with a kidney disease, and that person wants to give the kidney to a unknown person. Then this altruistic donor candidate is incorporated to the kidney exchange program to perform a donor chain, as you can see below in this slide. With this undirected donor, this altruistic donor, we have performed 6 transplants, and 5 of them were patients with an incompatible donor, and the last one patient of the change is a patient of the deceased donor waiting list. And we have done another step, and we have coordinated a very nice international activity between Italy, Portugal, and Spain, which is the International Kidney Exchange transplants. We have performed 8 international transplants by exchanging the donors of incompatible pairs from the different countries, and we are very happy because they were very difficult to match recipients. But the direct transplant has also or can also be performed when there is not compatibility between the donor and the recipients. There are different programs, not only put in practice in Spain, but also in other countries, that are based on specific medication and desensitization therapies to make a incompatible transplant possible. And with all these measures, we have increased our figures from below 100 transplants in 2005. As you can see, we performed 87 to more than 300 in 2019. 2020 has been a very weird year and a very complex year due to the pandemic, as all of you know. And this is the other approach that Spain has done. And it is an audit to transplant center, just to know the strength of the programs in our country and the weaknesses of our transplant teams to perform living donation. We have analyzed the results and performed recommendations in this document that I'm afraid it is in Spanish. But we have gained, and this is a very nice news, we have gained, or we have got a high consensus among nephrologists, nephrology nurses, urologists, immunologists, transplant coordinators, the O.N.T, and patients association. So we hope these recommendations increase our living donation activity next years. And I have two very important slides from this document. One of them are two questions performed to our centers. It's the information on living donation and preemptive kidney transplants performed to the patients with end-stage renal disease, but before initiating dialysis. And to the question, does the reference transplant center inform usually about living donation and preemptive treatment? 93% of the centers asked answered yes, which is a very, very nice, a very good news. But asked those centers if their referring hospitals inform usually about living donation and the possibility of preventive treatment, only 50% of the centers told us that their referring centers inform properly to the recipients. So we have here a big room for improvement. And asked the centers for the length of time to complete the living donor assessment. 30% of our centers told us that they needed more than 3 months to complete the living donor assessment. And this doesn't mean that at the end of the living donor assessment is the transplant, because between this complete assessment to the transplant, there are other more 4 weeks more to agree on a surgical date. And these are the conclusions of the document. The 75% of the living donor kidney transplantation in Spain is performed in only 8 centers, and there are big variation between centers, as you can see in the right part of the slide. The attitude towards living kidney donation is more positive in transplant centers than in those ones without transplant units. There is a lack of information in hospitals without transplant units, and it is essential to improve the coordination between these referral and non-referral centers. A pre-end stage kidney disease care unit is essential to inform patients properly about different options and offer living donation. And regarding the living donation assessment, a clinical pathway should be done in order to avoid delays on the evaluation of the donors. And more than 50% of the units do not register their reasons for a non-proceeding living donor kidney transplant if there is a medical contraindication or there is a donor refusal or so on. And this is another improvement area. And at the end, we have a lack of resources because we have a very, very high number of deceased donor kidney transplants, and our human resources have not increased in the same way as the kidney transplant has been performed. So we need to increase our human and also material resources. And this is my last slide with some messages that I would like to give you to take home. And they are that preemptive kidney transplantation improve both patient and graft survival and is the best option because it avoids also comorbidities associated to dialysis, may improve patient employment, and is cost saving. And it is, or it can be achieved from living donation. So every country should put in place strategies to increase these numbers. And they can be done by educate physicians and patients for early referral to the nephrologist, to develop end-stage kidney disease care units with well-trained professionals, because it is essential to inform properly on the different renal replacement therapies and offer living donation as preemptive therapy, and to look for the adequate moment for this conversation, this information, depending on the GFR of the patient and the stability of the disease. Also to improve coordination between referral and non-referral centers to inform everyone independent of where the patient lives, and to work on efficient evaluation processes just to avoid unnecessary delays. And that's all. I will be happy to discuss with you wherever you think it is necessary. Thank you very much.